And hi again, everyone. Welcome to another edition of Healthcare Unmasked presented by UTMB. I'm TJ Alds, your host here at I-45 Now. Forgive us. Last week, obviously, we had rough weather, and also our main guest had scheduled up surgery. We didn't put too much of a deadline on him for that to come with us, but we're glad to have on with us talking about an important subject that's about strokes. May is Stroke Awareness Month, and joining us today is Dr. Peter Can. He's in the Department of Neurosurgery and the Robert L. Moody Distinguished University Chair and inaugural chair of the Seeley Distinguished Chair at UTMB Health. That's a long title there, Dr. Can. But and his second visit, we keep track of how many of our UTMB doctors come on with us. And Dr. Can, thanks for joining us again today. We're glad to have you here and talk about a very important subject out here in the community.
Well, thanks, TJ. Thanks for having me. Let me try to share my slides here, TJ.
Yeah.
So,
and forgive us a little bit. We just got this working, so we got to make sure it works again. I'll have you switch over to your slide presentation first.
Can you see okay, TJ?
Let's see. Right now, we're seeing your screen. Yeah, we'll go ahead and go wide here. There we go.
Okay.
Hopefully, our audience can see it as well. And again, for those of you just joining us, and if you have questions, you go ahead and start submitting those now in the comments section, and we can take those a little bit later if you like as well. But again, Dr. Peter Can, professor and chair of the Department of Neurosurgery at UTMB Health. And Dr. Can, let me ask you first up, before you go into this presentation so people can understand just exactly what is a stroke so that folks can understand. We hear that term a lot, but I think a lot of people don't know.
So TJ, the talk is going to address it, but there are different kinds of strokes. The most common kind is basically when there's a blood clot in the major blood vessel, blocking supply of blood and oxygen to the brain, and then the brain kind of supplied by that dies. So that's the most common kind of stroke, we call ischemic stroke, and that'll be the focus of the talk. But there are, of course, other kinds of strokes, such as bleeding the brain, that we call hemorrhagic stroke. Again, we will kind of dive into that pretty shortly after we start.
Gotcha. All right. Well, I'll turn it over to you and let you walk us through it now.
Perfect. Well, thanks again, PJ, for the kind introduction and for the invitation. So, as you said, May is Stroke Awareness Month. So I just want to take the next hour or so to kind of discuss with our callers what a stroke is, kind of the treatment of strokes, what causes it, and and so forth and so forth. So I thought we'd start with the scope of the problem. So ischemic stroke. So 800,000 Americans each year suffer from ischemic stroke. In the U.S., it's the leading cause of adult disability, and it's the fifth leading cause of death in the country. So it's a big public health problem. If you look at it worldwide, stroke is responsible for more deaths each year than AIDS, TB, and malaria combined. So the problem, of course, is a worldwide problem, and it's not just in the U.S. As we know, stroke is mainly a disease of the elderly, not all the time, but mainly. So people above the age of 80 represent 4% of our population, but really about 30% of all the strokes that occur. And it's not surprisingly, with an aging population, the incidence of stroke is projected to increase. So right now, as we mentioned, 800,000 a year, and the number is expected to rise linearly with time. So, TJ, back to your first question. So what is a stroke? I think it's important. I think most of our listeners are patients, so I think I want to kind of really target it to our patients. So a stroke is a blood clot that lodges in the brain artery and puts the brain beyond the blockage at risk of death because of a lack of oxygen and nutrients. So you can see from the diagram on the right side, you have an artery, the red part, and it comes and erupts stop from a blood clot. And then the brain, which is that gray part beyond it, is at risk of dying because there's lack of oxygen and nutrients. So this is what we call an ischemic stroke, which is the most common type of stroke. About 80% of all strokes are ischemic strokes. And as I mentioned, other kind of strokes sometimes can get bleeding in the brain. The bleeding kind of stroke is what we call a hemorrhagic stroke. It's much more rare. It's only about 20% of the time. So for the purpose of the talk today, we'll focus on the most common one, which is the ischemic stroke. So a follow-up question, a natural follow-up question is, well, the clot is in the brain, but where do the clots come from? And there are a few common places. The heart is a common place. So that's why when we look at, when we study why people have strokes, kind of cardioembolic or strokes that start from the heart is quite common, 30%. The strokes, of course, can also come from arteries, whether it be arteries in the neck that supplies the brain or arteries in the brain themselves, so either from the heart or from the arteries, either the neck or the brain. And for the younger people, so stroke, even though it's more common in the elderly, as we pointed out, it can also happen in young people. And in the younger people, it's usually a much rare cause of the stroke, either something called like a dissection, which is an injury to a blood vessel, or it could be from a blood clotting disorder, which is also quite common for young folks with strokes. And the interesting thing, TJ, is that despite all of our investigations and fancy tests, about 30% of people never know where the clots came from. We call these kind of cryptogenic strokes, so strokes of unknown cause. So this is kind of like the big breakdown of it.
Yeah, and before you go on,
sure.
I found that very interesting that about almost a third of the strokes, you really don't know what the cause is on that. How much is being looked at now to really try to better define those causes? Because we can deal with the other 65% there, but it's that, what do you do about that third of the cases that they're just not know where this came from?
Yeah, so unfortunately, TJ, this is a common scenario, as you point out. Almost a third of people here leave the hospital without knowing why they had a stroke. A lot of the secondary prevention measures are the same, and unfortunately, these people, we don't have a cause of it. Certainly better imaging techniques exist now. For example, like now, maybe we figured that some new entities, for example, like there could be webs in the carotid artery that can cause strokes that wasn't recognized before. So certainly with improving imaging, we're making kind of more and more and better diagnosis to know why people have strokes. But I think at the end of the day, we have to accept that probably close to 30% of people walk out of the hospital don't know why they had it. And all we can do is to do measures to prevent them from happening again to the best of our ability, basically.
And for those of you just joining us, you're watching Healthcare Unmasked, presented by UTMB Health. Dr. Peter Kan, he is the professor and chair of the Department of Neurosurgery at UTMB Health, and we are talking about strokes. This is Stroke Awareness Month, the month of May. We're coming to the end of that, but this is not something you should only be aware about in May, just like we say about breast cancer in October. Always be there. And you get right to my next question is that not only are strokes treatable, but they're also preventable for folks. Talk about that.
Yeah, correct. So we talk about what is a stroke, where why do people have strokes? So this is an important message for our audience. So stroke is both preventable and treatable, unlike 30 years ago. So it's preventable because there are risk factors, some of which of course cannot be modified: your age, your sex, your ethnicity, and genetic factors. But actually most of them can be. For example, high blood pressure, cardiac disease. We mentioned 30% of the strokes came from the heart. So there are things we can do to reduce the risk of strokes with heart disease. For example, blood thinners, diabetes, high cholesterol, cigarette smoking, excessive alcohol, and physical inactivity. So these are all kind of modifiable risk factors. So just keep in mind that strokes are preventable. These are the things you can do to reduce the risk of having a stroke. I want to get into this concept a little bit, TJ, of a large vessel occlusion, because this will be important for discussion of the treatment. So there are many different kinds of strokes, and this is the worst kind of strokes. Basically, this is when the blood clot lodges in the largest artery that supplies the brain. And for the discussion of today, we call these arteries either the internal carotid artery, which is an artery that started from the neck, or the middle cerebral artery, which is an artery that branches off the internal carotid artery. I guess this is probably a nice analogy. This is the recent Suez Canal blockage. So basically, it's exactly the same kind of concept. You have a big vessel, literally no pun intended here, a big vessel blocking the pathway of blood supply. So again, the large vessel occlusion really refers to blockage of the big vessel supplying blood to the brain. So next important kind of knowledge for our audience is what do you look for? How do you know you're having a stroke? So the acronym is BFAST. B is for balance. So typically you know that your balance may be off. E is for eyes. Your eyes can be either kind of deviated, kind of move to one side or another, or you can have trouble seeing. FAST is face. So the facial droop is a well-known quantity to everyone. A is arm, so weakness. S is speech. It can either be slur or you can have trouble initiating speech, trouble understanding. And the T stands for time. So time is brain. And we'll kind of move on that later on to discuss the relevance of that. And just if we have any EMS colleagues or EMS providers on the call, so what scales should you guys use? So these are three kind of popular scales. One is Cincinnati pre-hospital scale, one is the LAMS, and one is the RACE score. And all these scales have something in common. They're relatively simple, and they allow a quick way to assess the patient having a big stroke or not. As you can see here, these are the cutoffs. And the advantage that once you identify that your patient's having a big stroke, based on those fast symptoms, then you can send them to a comprehensive stroke center or a level 1 stroke center like UTMB Galveston, where we can really treat this stroke in a comprehensive fashion. As many of you may know, that once you get to the hospital, then the assessment becomes more detailed, and the standard stroke scale is called the NIH stroke scale. This is the universal stroke scale that we use to assess all stroke patients, and anyone with 20 points or more is indicative of a severe stroke. And stroke scales goes from 0, which is normal, to 42, which is the most severe stroke that you can have.
And we should point out that print was a little bit small for folks. We'll come back to that, and I'll enlarge that when we get into our question and answer session, so we can kind of look at that scale a little closer for folks there as well.
Sure. And this is the T, TJ, for the BFAST. So time is brain. And why do I say that? So these are the studies, and I think it's worth kind of at least reading this. So when we have a typical large vessel occlusion, like the ones I talked about, the blockage of major vessel, every minute you lose about 2 million brain cells and 14 billion connections and about 7.5 miles of fibers. So every minute, like your brain is under this kind of oxygen deprived condition, you're losing a lot of brain power per se. And in terms of outcome, we know that delaying of care is really detrimental to outcome. So if you have this large vessel occlusion, every 1 hour in delay is associated with a 20% reduction in good outcome. So you certainly don't want to wait. So if you're at home listening, if you have these symptoms or the fast symptoms, you should really come to closest emergency room as soon as you can. And TJ, this is another way of saying the same thing. So as you can see on the horizontal axis is time, on the vertical axis is chance of having a good outcome. So as you go off in time, the chance of getting a good outcome reduces, and the chance of dying actually from a stroke increases. And at some point in this magic 6-hour mark, the two lines kind of cross. So certainly if you go beyond that, your chance of dying becomes perhaps more significant than chance of having a good outcome. So that's why just keep in mind the 6-hour mark, and it'll be important to our discussion going forward. So next, we talk about what a stroke is, why do people get strokes, what are the symptoms, how do we assess, and what are the treatments? So really, from the beginning of time to 1995, not really that long ago, there's no treatment available. So I still remember even when I was in college, when you have a stroke, there's nothing you can do. You just park them aside in the ER and hope they don't get another stroke. But in 1995, a landmark study came out from the New England Journal of Medicine, basically showing that if you come within 3 hours of a stroke and you get this IV clot buster, what we call IV TPA, your chance of having a better outcome or a good outcome is much higher than if you don't get it. And 12 years after the original study, now the time window is extended to 4.5 hours. So again, it's important to our audience to know that if you have a stroke, go to the hospital quickly, because within the 4.5 hours, they can give you the clot buster to improve your outcome. So there's something that we can do actively now.
Let me ask you on that there, because to go as long as we did, I mean, to hear that we didn't have an effective treatment till 1995, I think would be shocking to many people, because nowadays there is so much available to not only treatments beforehand, treatments after, and treatments if you're coming in feeling like you have stroke symptoms taking place, that this really is all kind of recent treatment plans that have come across. How did that come about? Was it just before? Is like folks, it was just too much of a mystery in the medical field, and that's why there really wasn't a treatment plan? Then finally someone said, wait, this is its own class. If we identify it here, we can finally figure out what to do here.
Yeah, great question. I think it took a while to do the clot buster, and actually a lot of this idea is borrowed from the cardiologists. The same thing happens in the heart. That the idea of a heart attack, a brain attack, is the same. So the IV clot buster is kind of like an idea that born out of that concept. And I'm going to go through why it took so long. I mean, it's kind of exciting as a neurosurgeon. It all can happen during my career time. So after the clot buster, it took a long time to really get the acceptance of pulling blood clots out, from the brain as we do right now, because of the evidence. It really took about 10 years and a lot of negative studies, TJ, before we got it right, and then have kind of solid positive data to support what we do. So let me kind of show you this next couple of slides. So why did I go back to large vessel occlusion? Because these are the worst kinds of strokes. As you can see here, 5 times higher mortality, 3-fold reduction in good outcome. And they're pretty common. I mean, like a fifth of these ischemic strokes are these terrible large vessel occlusions. And of course, the other reason because they respond poorly to the IV clot buster. And you can imagine if you have a lot of burden of blood clots, the IV clot buster may not work because there's just too much clot for this to work. Because of that, and these are just numbers to show that if you have the large vessel occlusions, the chance of it working is quite low. In some cases, even less than 10%. So it's really because of these large blood clots, surgeons have come in and then developed ways to remove them. So we know that the clot buster doesn't work most of the time, so we need other methods, and so we've designed kind of stents, and I'll show a video at the end, TJ. So there's stents that we can use to pull these blood clots out. That's the diagram on the left side. And then diagram on the right side is essentially like a little vacuum tube that we put into the brain through the blood vessel, and then we kind of aspirate and vacuum the blood clot out. So it took about really 10 years, TJ, since we have the technology to the evidence. Without evidence, it's hard to justify to do what we do. So went through a period of 10 years before we have that. And this is what happened. So in 2013, actually, there are a lot of negative studies coming out of major medical journals saying that maybe this doesn't work. And it's only until 2015, about 5-6 years ago, that we know that this for sure helps people. And these are the conditions, So basically, for this to work, you have to use the new therapy, like the stent and that I showed in the last slide, the stent removing blood clot. And it has to be done quickly. It has to be done within 6 hours. Like we talk about that 6-hour mark. And of course, for these devices to work, you have to have the disease, have to have the big blockage, and patients should have symptoms from it, so we know that go back to this anti-stroke scale we talk about, you have to have a kind of moderate to a severe stroke before we consider you. And if you fit all those criteria, there are 5 studies back to back from the New England Journal of Medicine showing that your chance of getting a good outcome, which is independent by yourself at home in 3 months, is much better if you have the therapy compared to if you don't have the therapy. So really, that's a very great year for the stroke community, because for the first time we have kind of level 1A evidence to support kind of this clot retrieval. And it was very big, TJ. It made it to the New York Times. It made it to all the major presses about this. And just to put this in perspective, I want to introduce this concept to our audiences. It's the concept of number needed to treat. So you can see here, this concept is just basically how many people do you have to treat to save another person. So these studies are so powerful, TJ, that you see this Extend-IA trial. It shows that you only got to treat 3 people to prevent, to have another person to be functionally independent at 3 months. So every 3 people you treat, you save another person. And you compare this to STEMI, to heart attacks, and doing kind of coronary angioplasty and stenting. In that case, you have to treat 17 patients to save another patient from a heart attack, stroke, or death. So this therapy, a lot of people I think rightfully say that is as powerful as almost antibiotics for infection. This is like a game-changing therapy, something that now we all take for granted. But I could tell you that even 6 years ago, when I was already an attending, that we weren't so sure at that time. So
if I can back up there just so we can clarify to folks, because I myself I have this question. Tell me the differences here where it says MR clean. That's not Mr. Clean as I would think. I think it's MR clean, escape, extended IA, Swift Prime. Explain the differences of those so folks can understand.
So these are all different kinds of studies, essentially. So as you know, to prove something, you need different studies, but they're essentially all studies from different countries. So MR Clean or Mr. Clean is a catchy name. It's a study from Netherlands. Escape is a study from Canada. Extend-IA is a study from New Zealand, and Swift Prime is a study from the US. So these are different studies looking at patients with the large vessel occlusion, whether or not they get the thrombectomy. So they compare the 2 groups, and they all have the same conclusion as you saw here. So these are the the results of the 5 studies, and really unequivocally showing that the benefits are tremendous for our patients. So, and again, very informal, TJ. Stop me at any given point if you have questions, okay?
Gotcha. You got it.
So, yeah, go ahead.
And then on this research we've done, you talked about a game changer. Again, that tight timeline. I don't think a lot of folks realize how advanced the treatment and diagnosis has been for stroke since 2015. I didn't even realize that date of 2015, just 6 years ago, that really what we know today. We hadn't, some of you in the field may have had an idea, but you yourself said you've been in the field. And if it not for this study, things may have not leapt as far forward. So when we talk about 1995 to essentially 2015, it was the same thing over and over and over again without having that data to support it. Is it, and obviously we're used to things, this past year, the pandemic, of things getting done so quickly on this. It does bring in reality. It takes a while to collect data on healthcare issues and to see, okay, what did we do here? And let's see what its effects are 10 years down the line, 5 years down the line, and those arcs. I would take it. That's why we're seeing that kind of groundbreaking. And it finally came to a head to say, yes, this is effective.
Correct. Because DJ, it probably takes a good 10 years for technology to mature to a point you can do it, right? And then another 10 years to figure out who you should do it to, So that's where I think the trials and technologies kind of come in play. And the studies, of course, in this case is instrumental. I could tell you even 7 years ago, insurance company used to deny this procedure, which in retrospect is
right.
It's mind-boggling. It's one of the most effective procedures, but without data, sometimes it's hard to move forward. So this kind of brings up the next point, So you mentioned about the time, and time is brain, of course, and so people start asking questions, TJ. That how about beyond 6 hours? If you have a stroke, beyond 6 hours, should you still get this therapy? If you have this large vessel occlusion, and the answer, also to our happiness is yes. So if you select the patients properly, even if you're beyond 6 hours, up to 24 hours, and you come into the hospital and you get this therapy, your chance of getting a good outcome is still much higher than if you don't get the therapy. And again, this number you need to treat, even in this group of patients, is free. So it's still a super beneficial procedure. So again, for those of you who's on the call right now, if you have any stroke symptoms, even within 24 hours, come in. You may still be a candidate for this mechanical thrombectomy. And now, what is the difference between these two groups, TJ, the less than or above 6 hours? So if you come beyond 6 hours, we want to select the patients out there who do well. So again, just like the therapy have made a tremendous improvement, the imaging itself has also made strides. So here is a perfusion scan. So it's basically a fancy imaging that you can get. It's a fancy CT that you can get to understand how much of the brain is still salvageable and how much of the brain has died. And obviously want to pick out the patients who still have a very large salvageable brain tissue, what we call an ischemic penumbra. So we want to select out the people who have a big area of brain that can be salvaged, and then we offer these patients thrombectomy, and they do great. So in the last kind of 15 minutes or so, I want to leave some time for questions in the video that I kind of want to just kind of give a flavor on kind of where we are today with thrombectomy and where we're heading, TJ. So the first box kind of shows you where we are, right? So right now I kind of set that if you come in, you have a kind of moderate severe stroke, if you can have a large vessel occlusion, and if we can treat you early on within 6 hours, we do this thrombectomy, and I'll show you I'll show you the whole procedure in terms of video. And there's no question that this is the standard of care. So what we're not sure about is that how about if the blockage is a little bit further down the stream? If it's not blocking the Suez Canal, but blocking the kind of like the branches or the downstream tributaries of the canal. I mean, with the smaller blockage, should we still do it? And how about in other vessels, not just the internal carotid artery or the middle cerebral artery? How about in outer arteries? There's just terminology. How about the anterior cerebral artery, vertebral artery, basal artery, and posterior cerebral arteries? Should we do it kind of further down the stream? Should we do in outer arteries? That we're still kind of studying. And how about patients who comes in with a pretty big stroke already? If we know that the area that we can salvage is less, do they still benefit? Since the procedure itself is so beneficial. And how about people who come in with milder symptoms, knowing that they may decline clinically, with time? Should we intervene in those people or not? So these are the questions that we're still kind of trying to answer through clinical studies. So, and of course, the other big question is about IV TPA. Right now we talk about the standard care. We come in for half hours to get the IV clot buster, but if we already know that you have a big blood clot, that the IV medicine may not work, should we just skip and go straight to the clot retrieval, or should we give the TPA first? Even that is not a completely known fact at this point. So I would just want to go through these points one by one, TJ, and just update our audience kind of where we're at and where we're heading. So in terms of the large vessel occlusion, should we redefine it? For example, should we expand that box? So rather than just calling the internal carotid artery or the very early part of middle cerebral artery large vessel, should we call kind of further down the stream middle cerebral artery, should we call that large vessel occlusion? Or can we call the basal artery, the vertebral artery, the posterior cerebral artery, anterior cerebral artery, and others? Should we call those large vessel occlusions? And some of these things we have answers to already. So these are the, TJ, you see the same names of these trials, so the same trials that I show in the previous slides, So in these studies, they actually include a fair number of patients where the blockage is a little bit further downstream. So not so much of the super large vessel, but a little bit of the kind of like the middle, medium-sized vessel occlusion. And also, thankfully, that when you look at all these studies and you look at these groups of patients, it still shows that this clot retrieval therapy is beneficial. So even if you have a more kind of further down the stream kind of occlusion, as long as it's not too far down, you should still do it, because the outcome at 3 months is much better compared to patients who didn't get this therapy.
And just so maybe people who are watching and can see those arrows, we had a red arrow on the first slide, and then we had these white arrows. Can you explain what those arrows are pointing at there, so we can?
Sure.
I would think it's the occlusion we're showing here, but
can you see the moving arrow right now, TJ?
It's a little bit there. Folks may be able to see it there. It's to the right of your screen where you see that image. You'll see Dr. Can's cursor moving around. Okay.
So, TJ, so when we first defined the large vessel occlusion, so this is the internal carotid artery. That's a large vessel. And this is a early middle cerebral artery. That's a large vessel. So the question here is that if you even go beyond that on the more kind of downstream part of the vasculature, the vessel tree, we're showing that even here, if the clot is here, even that is beneficial. Now, we're really talking about few millimeters in difference, but in doing this kind of work, the difference is really a few millimeters. It's really kind of precise territory. So, thankfully, we showed that even that is kind of beneficial. And of course, there's a limit, right, TJ? You can keep marching out to smaller and smaller territory, right? And the benefit as you go out, it diminishes, because the further out you are, the less brain that small arteries supply, and the higher risk it is to pull a blood clot out of there. So at some point, the risk obviously will outweigh the benefit. So I think kind of beyond where I show you in the last slide, for now we don't typically do them. So next, the Basal Artery is an interesting artery to look at. I added a few slides because there's actually a study that came out of the New England Journal of Medicine last week, showing some new exciting, some new data. Not sure it's exciting, but some new data. So basically, the basal artery, TJ, is the most important artery in the body. If you have a blockage in that artery, typically it's not compatible with life. So in the past, these patients always come in pretty severe condition, and when we look at it, there is some trend for improvements, in outcome and in functional independence, but there's also some higher risk of bleeding in the brain. So, most people who do this line of work, like myself, we don't hesitate too much and treat the patients, because we think it's the alternatives are poor. But again, we're still kind of in the face of generating this kind of evidence. And in fact, this is a study that just came out of the New England Journal of Medicine, showing that for this particular artery, TJ, if you can see my screen here, the basal artery is this kind of artery in the middle of the brain. If this specific artery is blocked and you're going to retrieve the clot, in this study, it was what we call a negative study. It didn't show that the group that got the therapy compared to group did not get a therapy really made a difference. So, but that's just one of the trials. So we're hoping that more trials would come out and support it. As you saw in the previous studies, sometimes it take many kind of negative trials to really bring the
Right.
real set of patients to light in terms of who we should treat. So
I think we've heard this a lot over the years from particularly those who are doing research into treatments. That it's like you learn more from your failures than you do from the successes along the way. When you have something that may not come across as being conclusive, you go, okay, what do I need now? I know that doesn't work. It's almost like a process of elimination. And I wonder if, just for those who may be coming in later here, if you can explain what we're seeing in that right-hand chart there, this treatment, the intravascular therapy that you're showing here for stroke in there. Again, you already put the Basal Artery. It goes essentially the middle. It's the large artery goes in the middle of the brain, correct?
Correct.
For that.
So,
okay.
So TJ, can you see my cursor circling?
Right.
So these arteries, they're called great vessels. They start from the heart. You see, it starts from the heart. It's called subclavian artery. And then the vertebral arteries, you have one on each side, and they come together to join to form one artery called the Basal Artery, probably the most critical artery of the brain, And so for a long time, we think that, well, if you have a blood clot there, why not just pull it out, And this is an area that the other studies in 2015 did not address. This is the one location they did not address. So here we are. We think it should be beneficial. So we did the study. It took a long time to recruit patients because most people think that it's not even fair to randomize patients because if you have a clot there, why wouldn't you remove it? But the truth is that, we still need some more data. In this study, you can see the medical arm and the kind of surgical arm. The outcome data is not so different, So again, I just want to point out to our audience is that just because of one negative study doesn't mean the results is not. The therapy is not beneficial. In fact, if you even look at these numbers here, there is a trend that patients do better. 44% of people were independent at 3 months, compared to people who did not get the therapy. It's just the results did not reach significance,
Right. The idea is that you're always kind of shooting for that 60%, right? And to be able to show, okay, this is a successful treatment. In this case, it does help people with the treatment. And that's why I wanted you to kind of go over this again, because what would be classified as not successful actually is successful for some. And that's a step forward no matter what.
Correct. So, so I think there's what we call a trend, TJ. It's just that I guess it's the fancy way. The kind of more general way to say is that we could not rule out that this difference is due to chance, basically. So that
right.
This is the more general way of putting the results. So, just to let you know, of course, people are not giving up. There are more randomized studies coming up, and there's a study ongoing in China right now looking for the same thing. And I think really, TJ, I've had many patients of mine who have this problem who has done great from it. So my hope is that I can come back in a few years and get this talk again, and then say that now we have evidence to show that the basal occlusion is beneficial to be treated also. So I just got a few more slides, and we can show the videos. So this is a different group of patients, TJ. So we talk about, you remember when we talk about the 6 to 24-hour patients, we want to select the people who have a large salvageable brain area. But some people ask, well, if the therapy is so beneficial, can you be a little bit more, can you be a little bit less strict about the inclusion criteria? So, for example, if people come in maybe with a smaller salvageable brain area and larger stroke, would those people benefit too? The answer is probably yes, because if you look at this kind of busy chart down here, is that even you may have come in with a larger stroke burden, if you get the thrombectomy, your outcomes are still better than if you don't, But again, there are studies, ongoing randomized studies right now looking at that. They have all a fancy, easy to remember name. One is called Tesla, one is called Tension, one is called In Extremis. So these are studies looking at if you are coming with a pretty big stroke already, should we intervene? Again, hopefully in a few years we'll have the answer to this, and we're excited to for that. And the last two things we'll kind of already touch on that I want to kind of finish concluding is that how about patients who come in with mild symptoms? So these are people coming with a big blood clot in the brain, but because of the way that their arteries are structured, they're tolerating it. They're mild symptoms, but we're always worried that these people would decline if we don't do anything. So should we treat them or should we not treat them? So again, we need more evidence. And these are the studies, TJ, the endo-low study and the MO study. These are studies that are looking at people with milder symptoms, but with a large vessel occlusion to see whether or not we should treat them. So again, really a very exciting field because there's a lot of science and a lot of trials being done to really see who else can we treat? Who else would benefit from this kind of very important and beneficial therapy? So the last thing that we were talking before is whether or not you need to get this clot buster, right? So we talked about if we know that you have a big clot, it's probably not going to work with the IV. Should we just skip it and go straight to the surgery, to the clot retrieval? So this is a study published in New England Journal of Medicine, kind of like a standard large medical journal from China, shows that if you have this big clot, you can probably skip the IV because the outcomes, the chance of a good outcome is no less if you just go straight to the cath lab and have this clot retrieved, and then you don't have to kind of go through and waste the time the IV medication that could potentially delay care. So, but again, there are other kind of American and European studies looking at that. The Mr. Clean is a favorite line of study, Mr. Clean no IV. And the Swift Direct is a study that is done in America. So what is the goal here, TJ? So we know that we talk about large vessel occlusions, a pretty common stroke, a devastating kind of stroke. About 20% of all stroke patients have that. And thrombectomy is a very beneficial procedure in some patients, as beneficial as giving antibiotics to infection. So basically, we're just trying to match the two. We're trying to see who else with this large vessel occlusion can we give this thrombectomy procedure to? So our goal, of course, is that eventually, more the merrier if we can come up with evidence to treat as many patients as we can. And I think finally, TJ, I think, after going through all those talks and slides, there's nothing more, I think, more impactful and more kind of meaningful to see like a case. So I was just going to play a case, and you let me know if you can hear it, okay? Because
Gotcha.
This will show kind of like the progression of the patient, the thrombectomy, and the outcome. Okay, so this is a typical stroke patient. It's an older patient who came in with weakness. So again, we just want to go through the symptoms, right? So left side is weak, the arm for the A, the facial droop, the F, the dysarthria, the speech trouble, the gaze deviation, the eyes, right? And the patient came in at 3 hours, so she was able to get IV TPA. And then she got a CAT scan of the eye, which showed there's a large blockage of the carotid artery. And then she was transferred to the hospital. So I'm just going to play this. Okay. So let me know if you can see it. Can
Okay.
You see it, DJ?
Ready to go. I can see the slide up, not the video yet. There we go.
Okay. So these are the arteries that goes to the brain. You can see the brain arteries, right? So this is the blood clot. Let's assume that it came from the heart. Again, just doing some reviews. So the most common place from the heart. So the blood clot is going from the heart and kind of lodging into the blood vessel.
Arm.
So you can see
Lift
here.
up your right arm. Lift up this arm.
So this arm is
Lift up
working
this
fine,
one.
right?
Lift up this arm.
Yes.
And you see the left arm cannot move.
Can you feel that? Lift up this arm.
So the left arm cannot move.
Can you lift up your arm? Yeah. Lift up this leg. Lift up the left leg.
You can see okay, TJ?
Yeah. And if we can pause it right there, so we can explain to folks here. One, this is a 70-year-old female with a sudden onset. So her left side of her extremities were, particularly as you see, there's her left arm, her left leg, she was unable to do it on her own. Obviously, she has and you could also make out that facial droop that you talked about there. But her right arm, she was able to bring up without any problem whatsoever. And she was able to make some basic responses to. I just wanted to have some folks kind of who may not have seen that first slide before we went into this here. And this was, as you said, 3 hours,
3 hours
from symptoms onset. Okay.
Right. And very important. I think that's why TJ, I want to use this video to tie together all the speaking points, about the presentation. This is how it looks like. So if you see this happening to your family members, then you have to call 911. This is an active acute stroke.
Okay.
Okay, so I'm going to keep playing the video. You see okay?
Yes.
So this is what we do for this kind of procedure. Here we You can see where the blood clot is. So now we're injecting contrast in the vessel, and you can see the vessel comes up to a very abrupt stop because that's where the blood clot is, TJ, and it's blocking the blood from flowing beyond that. So no blood flow beyond that right here, okay? So here with wires and catheters, we basically go up to the face of the blood clot and beyond. So here the wire kind of went through the blood clot. And the catheter is kind of going, going beyond that. So now we're through the blood clot. This is in the normal blood vessel. And here now we deploy the stent. So we open up the stent here. And then now there's blood flow through the clot into the brain. So now we call this an ischemic holiday. So the brain is getting a holiday from the stroke, basically. Now there's blood flow through it. Once this stent is open, now there's flow through the stent.
This is essentially would be just for layman's terms on this is that you've drilled through the obstruction, and that has allowed the blood to flow through. Is that the best way of saying that there?
Correct. Sorry, teacher. Let me see if I can get back to
get back to that because that was.
Lift up this arm.
So let me show this here again here.
So again, for those watching here, you can see I call it in this case, using what we call the canal of blood going through in the vessel there. And that big red splotch is the actual clot. And essentially you're able to put a stent in that clot, widen it up so blood flows through it again.
Correct. So now you can see like the blood is actively going through this, TJ here. So the next step is to pull the stent out with the blood clot. So this is what it looks like in real life under the x-ray. And then here we kind of inflate a balloon in the neck. So we stop the blood flow from going forward so that the clot cannot break loose. And now we retrieve the blood clot all the way from the brain, all the way down to the neck vessel. So you see how we just pull it out into this tube, and then we take this tube out of the body. So this is what the clot looks like on the
and how big when we're looking at that clot that was in the dish there, about how big are we actually looking at there?
It could be like an inch, it could
wow.
be like an inch long. It could be shorter, it could be like half an inch to an inch. Okay, so now take a look at this here. This is right after the
good. Can you smile? Good. Can you lift up this arm, your right arm?
It's my left leg.
Oh, yeah, your left arm. Can you lift up your left leg?
You see,
wow.
So this is so I'm going to fast forward this a little bit here. So,
Good. Right. So can you smile really big?
So this is.
Tell me your name.
This is the day after.
Where are you now?
St. Luke's Hospital.
Perfect. Can you lift up your left arm? Can you lift up your right arm? Can you hold them up and close your eyes? Good. Put them down. Now lift up your left leg. Good. Lift up your right leg. Good. Can you do this? Can you play the piano?
No.
Like this? Do that.
Let me just ask you, Dr. Kent, with Mary here, how from that first video we saw where she couldn't lift up her left arm to that video where she was able to lift up her arm at least, how much of a time frame was that?
Yeah, so we really try to achieve, from the groin puncture to the retrieval in an hour. So probably, you're talking about an hour and a half. That's how fast we're trying to do this procedure.
Amazing.
As we know, time is running. And I want to show the video because I think this is more important than any of the slides because it shows the symptoms on how disabling the symptoms of strokes are, and what kind of difference can this therapy make to patients when you do it early enough. And that's why when I get the phone call about the thrombectomy, we just have to rush in the hospital and do it as quickly as we can because it makes a huge difference. I mean, like you're talking about changing someone's trajectory in life, like in a tremendous way. I mean, this patient, without this therapy, would go straight to a nursing home. There's no, or I mean, if she doesn't die from this, she'll go to the nursing home.
Right.
As opposed to now that she literally walk out the hospital like a day later, right?
I mean, because that's what I say. When we see her walking there, that's the next day.
Correct. So
goes from about 24 hours before not being able to lift her left arm, respond well, or move her left leg, to walking out of the hospital the next day. Amazing. Where when you, as you said, not too of a distant past, there would have been the case where she had gone into a nursing home or an assisted living center, we should say.
Yeah.
And I want to thank. I heard her name was Mary. She'd said her name was Mary. I want to thank Mary for being willing to have the video shown to everyone there, because I think that was probably I agree with you, and I would think our viewers would too. That was probably more informational than the slides themselves. Although I do note that showing the surgery, the procedure of putting a stent inside a clot and then pulling it out. How long has that really been around now?
We're probably been doing this for 15, maybe for that particular procedure, maybe for 10 years or so. Less than 15 years. But it's really since 2015 do we have the evidence really to back it up.
Wow, amazing stuff. Those of you just joining us, and you can watch the replay as soon as we're done here. We have Dr. Peter Can, who is the professor and chair of the Department of Neurosurgery at UTMB Health, and this is Stroke Awareness Month. And we have been talking about that, and that was a fascinating procedure there at the end. And the fact that this is really newer, I should say, not new, but newer advancements that are happening here. You had mentioned this at the beginning about how imagery has improved. I shared this with you the other day, and I want to share with some folks of my own personal story of the difference between 7 years. I had gone in, blood pressure was real high. They had done some scans on me and the like, and had dealt with blood pressure issues. Some 7 years later, I was having actually the same things happen again. I go in, and now, however, they do the same scans and all, but they're comparing them. And the doctor at UTMB had said, well, hang on for a second. This looks significantly different. We're going to keep you in and do some more tests. Now, as it turns out, what they were seeing on the scans, they were anomalies, were just the technology had changed. So they had the new technology that was able to really fine tune. It's like and I call it now the difference between having a tube television and HD television. And I would think, how big of a leap is it in treatment of strokes to have the better imagery technology as well, to be able to fine tune what you're able to do for treatment as well as surgery?
Oh, it makes a huge difference. If I go back to your very first few questions, TJ, that 30% of strokes are still unknown in cost, right? But the new imaging has really helped to narrow that gap, and hopefully, eventually, that gap will go to zero. But but the imaging really helps, and identifying things that we weren't seeing before with the more traditional imaging. And in terms of where this has gone, I mean, now this images. So when I started, I mean, the image quality is certainly a lot worse. And now not only the quality is much better, also it goes to your phone. So basically, when these images happen, so it's all about streamlining the process, to get to a patient as quickly as we can. So when a patient is getting a scan, there's a automatic, algorithm, that detects this blockage already. So it's not even, so the patient getting a scan, the computer already picked up the clot, already sent it to our phone and alerted us. So we already know that we have a patient here who needs, treatment, whereas, whereas
the fact that you could be somewhere else and then you're on your way to the hospital.
Correct.
You've already been able to look at a lot, and you're already several steps ahead of what you have been 10 years ago.
So it's just to show that 10 years ago, you would get a phone call, you get a page, and then you'll go to a computer, you look at the scan, and then you decide that, you call the team in. But now, actually, as the patient gets the scan, there's some echo there. But as a patient gets a scan, you're already notified, not just the physician, but the whole team, the techs, the nurses, and everyone is notified, and everyone's already coming in. So before the patient even leaves the scanner, so that has probably cut down at least an hour of time in terms of when we can get started. So which is really, really important, So I think not just the image quality, and of course this perfusion imaging is also being developed this year. I mean, this decade, I mean, it's really tremendous progress, but not just the imaging quality, but also the technology in itself, whether it be AI and smartphones and apps and things like that, has really revolutionized the way we treat stroke patients. And also even these scales, TJ, when we started, I used to carry a little card in my pocket to calculate these scales, but now you have an app. You just punch it in, or you have the patient look into the camera, and then they do the calculation for you. So it's automated and it's good. I mean, it's actually streamlines the process and makes the process a lot quicker. And again, I really thank the patient for allowing me to make the education video when we made it, because I think that is really important. So I really want to show to the viewers that, I mean, it's one thing to talk about the clot retrieval, about the numbers, about the charts and the diagrams, but what it means to someone who has a stroke, you really have to see that kind of video to understand the impact that this procedure has on people. I mean, we've treated many, people, young people, with young kids who are going to work and have a stroke, and you're essentially changing the quality of life, not to only that one patient, but to the entire family. I mean, this patient would would need to be looked after and cared for by the family, probably in a very significant way. So I think this is really a fantastic therapy. No doubt it's the most beneficial therapy that I do as a neurosurgeon, and this will only get better. We only treat more patients with it, and this will only get better.
You do more. One thing you talked about, that stroke scale, and I wanted to see if I'll see if I can zoom this up a little bit and do so we can get another look here. And this is that chart you'd shown, the NASA Institutes of Health stroke scale. And you have, a scale in some cases, up to 3, but most of the times 0, 1, and 2. And so when you get up to a 20 on this, and that includes, as we're showing here, level of consciousness, and LOC question. That's, asking basic questions that people should be able to know on the right time. At the same time, you're asking them, open your eyes, close your eyes, make a fist, let go. You saw that in some of the video with Mary there. Your gaze, open them up, follow the examiner's finger along the way. The visual sign is like, something else that would be there for the patient to be able to look at, to whether cover one eye, hold up, be able to follow it a normal way. The facial palsy, that's the droopiness in the face that we talked about. The motor functions of the extremities, left arm, right arm, in this case, as well. And again, as you add these up, if there is if you see something, or if it's more extreme, it's marked there, and the points get to 20, it's what's called a severe stroke. And so then you do the same thing on the motor functions, legs, left and right. Now you're checking out the other parts, finger to nose, heel down to shin, just shifting around. These are they're simple things when you look at them just on their own, but important in being able to say, all right, more than likely, this is a mild or a serious stroke. And you said you carried the card around. Now you have an app to do this for you, or help you do it, I should say. You don't do it for you, but you're able to track that. So I just wanted to show that to folks, that we'd shown this up so we get a little bit of a zoom in on that as well, which goes into, I wanted to, and no, go ahead. What you're going to say, Dr. Can.
Oh, no. Please go ahead.
It goes to what I wanted to kind of back on some things here, and we touched on this some. The question is, who is at most risk for a stroke? Because the common thought is, it's only older people that, I don't, really don't need to worry about this till I hit 70 years old, 60, 70, 80 years old. That's not necessarily accurate, is it?
Correct. And as we said, the incidence of stroke is obviously higher in older people, but strokes absolutely do occur in younger people. I mean, I've treated even children. I mean, children can get strokes, so obviously much more rare, but, young people and even teenagers can get strokes. So if you have those symptoms, don't let age deter you from going to the hospital.
Right. And it should be one of those things. And that's to encourage folks such as myself being stubborn when I was younger. I would have the symptoms and yes, it was found later not to be a stroke or something else, but still I had ignored the symptoms thinking, oh, there's no way it's a stroke because I'm younger and I'm okay and it shouldn't happen. That should not be the thinking process for anyone that may be feeling any of these symptoms. We talked about how you treat a stroke along the way. What happens before someone comes into the ER? What's the steps that everyday people should take if they recognize these symptoms? They're getting someone to the ER. Is there something they can do in between? You mentioned we mentioned about the EMS providers, but most people who are brought in are going to come in by private car many times. So when that happens, what should every day, if I'm with my mom or I'm with my father or someone, or I'm with a friend who may be showing the symptoms, what should they be doing outside of getting into an ER?
Yeah, I think the main thing is really get them to the hospital as quickly as you can, because we do need the imaging to determine, one, if they have a stroke and what kind of strokes that they have. In the past, people say, well, you may be able to give an aspirin, but I do think that is, now most people live pretty close to an ER, so I think that's going to be important, to get them to the ER and get the workup as quickly as you can.
Gotcha, and make sure to do that. So, and the other kind of thing we talk about sometimes is once you've had a stroke, then this is not like getting that you're not going to get it again. That's because of the conditions that exist. What is the what do you do? One is if you've had one stroke, how much is your risk for another, and then maybe more, because we've heard about that many times. And if you've had a stroke, now what do you do outside, changing your total lifestyle? As you mentioned before, stop smoking, watch what you eat, the normal things we hear all the time, but to prevent future strokes.
So the data is that if you have a minor stroke or a TIA, your chance of having another stroke is much higher, and it comes early, so the number I remember is 5% chance of another stroke within 5 days. And over 10% in 30 days, so pretty high, and most of it comes in the first month, So if you have a stroke or TIA, your chance of having another stroke is like 12% in the first month. Things we can do apart from the factors that we talked about, medications obviously help. We put people on antiplatelets, aspirin, Plavix, and cholesterol medications, like and so forth. These are what we call secondary prevention. It's to prevent you from having a second strokes. But certainly that's why it's important to come to the hospital. Not everyone needs a thrombectomy. But even people who don't get thrombectomies, there are many things we can do to lower the risk of having another stroke.
Right, and I should point out that was a decision that I had made with my physicians. Again, mine turned out to be a TIA. I mean, that's just so no. But all of a sudden, I was getting aspirin. That was. That, but also too, they wanted to make sure they ran enough tests and the like, and it was like, okay, we can do this outpatient, or we're going to check you in for the next 24 hours and do all your tests. And I chose the go ahead, check me in, and so I can get all the tests knocked out, and then a treatment plan done afterwards. Prevent. Now, fortunately for me, I had no other problems since that time, but I guess I would say I'm more aware now. And that comes to the question we talk about, what are the effects of stroke? There are two folks that need to be involved in this thing. It is yourself, recognize your own, but also those around you, of what should they be looking for. And you talked about if you see like a subtle palsy or, the droopiness of the face, you hear a speech slur up, which is what signaled. I actually happened to be visiting with my doctor, and she heard my speech slur, and that's what made her activate and send me on over to the ER. But what for ourselves should we be? Because a lot of times, let's just admit it, patients can be stubborn, and we can be, we do Dr. Google more than we do listen to Dr. Can, I should say. What do you what do you tell patients that, or anyone may be a future patient of? What should we recognize in ourselves that we may be susceptible to, not necessarily going through that, but be susceptible to a possible stroke?
Yeah, so I think I just want to emphasize those fast symptoms again, TJ. I think that's the main thing you should look out for. I think if you notice, any kind of weakness, I think that's usually having trouble speaking weakness. I mean, it's hard to see your own face drooping. Let's look in the mirror, right? But I think the face weak, the arm weakness is very obvious. The speech problems is often like a big clue that you're having a stroke. So I think those are the two balance problems. I think those are like the main things,
Gotcha. And then obviously too, we mentioned this too. You want to get yourself to, when you've done that scale and seen how serious it is, you want to get to a certified comprehensive stroke center. UTMB Health is one. What does that really mean though, for folks to understand? And is that only available on the island, or can be treatment also done in either the Clear Lake Hospital or NDR, or also at League City as well?
Yeah, great question, TJ. So right now, we have 2 stroke centers. The one on Galveston Island is a comprehensive stroke center. So that's the highest level of stroke care, meaning that we can look after every single stroke patients, from thrombectomies to kind of the bleeding kind of strokes and other things. So that's like a level 1 stroke center, So and the one now on the mainland, on the Clear Lake campus, we're heading towards comprehensive stroke center. But right now we're a primary stroke center, but with a thrombectomy capability, which means we can still do the thrombectomy procedure that we showed. But we're just not at the highest designated status yet. But we're heading towards that pretty soon.
Yeah, and the accreditation process on that's a little bit different than
correct.
It has to go through everything. You can do it and feel confident, but right now it's got to go through an actual process to get certified.
Correct. But I just want to tell a patient that for now, if you have a stroke, either one of our campuses offers the thrombectomy, which is the highest level of treatment that we do for stroke patients. So you don't hesitate. Please come on in, and we'll be able to help you.
And doesn't matter what ER you go to, quite frankly, get there first, and then get stabilized, and then they'll take it from there. And I do appreciate it. Well, Dr. Can, thank you again. I liked it when you're on because you always bring us good stuff. I call it show and tell with Dr. Can. I think I'm just going to call it that from now on. But you always have good information to share with us that also can show it to us. I still think showing the ship blocking the Suez Canal is probably the best example of how a stroke works for folks there too. So folks can understand that better. But also true, and again, we ever get a chance to meet her. And I will say, we did reach out to one of the UTMB Health patients. He was feeling under the weather and couldn't join us here today. So we're going to be trying to do more and more of that on Healthcare Unmasked, to have actual patients who have been treated who can give their personal experiences to you as well. Before we wrap up here, any final thoughts from you, Dr. Can?
No, just remember, be fast. If you have a stroke, come to the nearest hospital as soon as you can, because there's treatments.
Most important thing is that if you feel like it, don't brush it off. Get in for a treatment. That's the best thing to do at all times. So, Dr. Can, thank you so much. We're glad to have you on again. So you and Dr. Warren are in running neck to neck now of the most appearances on Healthcare Unmasked. So I'm sure one of y'all is going to try to break the record between it sometime. We do appreciate it. Again, folks, when we wrap up here, you'll be able to log on right away and watch a replay of this entire broadcast here. One, also too, happy Memorial Day weekend to you, Dr. Can. I hope you get to spend some time with your family and enjoy yourself. I know your wife was tuning in to watch. I hope she gives you a good thumbs up how you did on your presentation today, and we appreciate it. And to all of our viewers too, happy Memorial Day weekend to you coming up here this weekend. And whenever I say that, I do remember what the weekend is really about. Honor those who gave their life for this country in combat, and do take some time to honor them. We ask you to do so as well. We'll be back again in June on our regular schedule. As I said last week, we had to reschedule for this. Weather wasn't too nice either last week too. It kind of affected some of us, but we'll be back again next month, I should say. So we're glad to have you here. Dr. Can, thank you so much. I appreciate it. I'm TJ Alds, and this has been Healthcare